guys, welcome back to my channel. Today I wanted to go into what is medical coding. Believe it or not, I get a lot of questions on just the industry, what it is, and I'm going to go through what it is not. So first off, what is medical coding, right? That's like the number one question I get. And I still can't believe that a lot of us, don't understand. And I mean, when I first entered the profession, it was dating myself like 20, 24 years ago. And I had never heard of medical coding. But simply put, medical coding is transforming diagnoses, procedures, medical equipment, and services into alphanumeric codes. Then, once we obtain these codes are used for various purposes. They're used for billing and reimbursement, health records management, and statistical analysis, right? And I know that sounds probably like a big word, statistical analysis. Say, for instance, an agency in our government, and not just our government because it's international, wanted to see how many people during the flu season or the winter season actually had the flu. So for statistics, they could put in a code for the flu or the type of flu, and immediately a database would let them know how many people were diagnosed and treated with that. So let me take you through the books that we use to obtain these codes. I should have brought them to my desk, so bear with me. I didn't. Hopefully, be right back. So it is three. We have there is a software that we call the encoder, and there's various companies to do that. Computer assistant coding. That's what we have now. So that helps us with obtaining the codes. However, like we know, dealing with computer systems, they will shut down, and just dealing with a computer. So we still need to know how to use our coding books to obtain these codes. So we have, let me put them in order. All right, this book here, and I have so many books. I have that bookshelf here with coding books, if you guys can see, upstairs in my office. But this is ICD-10-CM, right? And this stands for International Classification of Diseases. This is the classical modification. This is the 10th revision. And this book is for diagnoses codes. So what is a diagnosis code? Diagnoses codes, simply put, cough. Any medical condition is a diagnosis. Pneumonia, I mentioned flu, fracture, pain, even when we go into the hospital to deliver children, those are diagnosis codes. And so a live birth, a baby, everything, every diagnosis is grouped into a diagnosis code. So we'll get that with this book, ICD-10-CM book. Then for procedures, we use the ICD-10 PCS book. And this is International Classification of Diseases, 10th revision, and procedural coding system. So all that is saying is the procedures. Like I mentioned, the diagnosis for fracture. And did they do a pinning, or what procedure did they do? Did they splint that fracture? Did they take that patient to the surgical suite and do an open reduction, internal fixation of that fracture? Let's see. Patient come in with a heart attack. The heart attack would be the diagnosis. The procedure would be maybe a heart cath, or if they had to take the patient in to get stents, coronary artery bypass graft, that will all be, and I know these are big words, but trust me, the more you do something, it gets less complex. Um, it's not even complex. It's just having the right teacher or mentor to teach you how to use the books and what to look for in the medical record. So that's ICD-10 PCS. And let me move these here. So last but not least is CPT, current procedural terminology. And CPT is used for outpatient settings, where outpatient settings would be your doctor's offices, your emergency room is an outpatient service, and they use E&M codes, which are found in the CPT book for that. Outpatient surgery, ambulatory service, anything outpatient where the patient did not have to spend nights in a hospital, that would be considered an inpatient stay. So we have ICD-10-CM, where you get the diagnoses codes. We have ICD-10-PCS, where you get the procedure codes. And we have the CPT book, where you get the outpatient services, or the HCPCS codes. And those are used for like durable medical equipment. And those are like, if you have to come home in a wheelchair because of the fracture. So those codes have to be on that patient's bill, so that the hospital facility or the doctor's office or the ambulatory surgery place, they can be reimbursed for those services and the medical care that was provided to the healthcare system or the hospital. So, coding. Another question I get is the longevity, and I always let people know, to me, coding is not a job. And I've heard people say, through the years, the acronym for job is just over broke. And in so many senses, I would agree with that. Healthcare reimbursement, healthcare revenue cycle, that's another word that I use for medical coding. And billing, I don't like to say billing, because to me, when I started, I would hear the infomercials on television, and even sometimes now, they're like medical coding, medical coding and billing. You really, to obtain I think the financial independence or the financial gain that I've been able to see, and a lot of my colleagues, and the path that my students are on, medical coders, especially for the inpatient side and outpatient side too, but on the inpatient or medical coders, they code the diagnoses, and depending on the codes that the coders put for that diagnosis, or how those codes are entered, depicts the reimbursement for that patient. So say I'm coding a chart. The patient came in with shortness of breath. They did an x-ray. The patient found to have pneumonia, right? Then the patient has a lot of other conditions, or what we call comorbidities. So maybe hypertension, diabetes, hyperlipidemia. Believe it or not, obesity is a disease process, and that's coded. If the patient smokes, like whatever that patient's history is, you see how the diagnoses are categorized into alphanumeric codes, or codes that we put on our coding attestation. Then in the hospital setting, those codes are transmitted over to the billing department, right? And the billers use those codes that the coders have coded for the patient, and send it to that patient's insurance company for reimbursement. Now, when we go into coding for, say, a physician's office, I'm not too familiar, but I am familiar in the stance like this. I hear people say, "Oh, I've done," they're medical assistants, and not knocking a medical assistant, but they're like, "Okay, I do medical coding." However, everyone in a healthcare setting has to do medical coding, right? Because that's how they get their money. Really, that's how they get their money. If we don't have coders, people don't get paid, from the CEO to the janitor, right? So, say your baby comes in, okay, medical assistant, I guess they have back office and front office. The back office medical assistant, usually they'll handle the billing, the medical coding and billing. Because, for an example, like I was saying, you bring your infant child, toddler child, teenage child, you go to the doctor's office, and the baby's up with a fever, screaming. So you're like, in the morning, I need to bring my baby in. My baby has a temp, pulling at his ears. Take him in. The doctor sees the baby, finds out the baby has an ear infection, which is medical diagnosis is oitis media. So before that physician or that healthcare facility can get paid for that hospital visit, it has to be coded. And usually, like for something like that, that's I can't even pediatric. So the medical assistant or the back office of that outpatient facility usually will have like a super bill, and it'll have all the diagnoses on there that they usually see. So OIDIS media is a code. So they would put that code on a billing form and bill it to the insurance company, right? So one or two codes. The inpatient side, you may have someone in the hospital for 5 days, 30 days, 6 months, racking up diagnoses, not racking up, but acquiring different diagnoses through the hospital stay of that patient. That patient may with come through the ED with chest pain. They do a cath, and they find out the patient has actually suffered a heart attack. So, and they find out that patient has 3 blockages in an artery, and then the physician wants to go and put maybe 2 stents in the patient's heart to open or remove the blockages from the patient's heart. So this is inpatient coding. So you'll have, I keep looking over there because I'm like, I'm gonna go through the steps. I'm gonna get my handy dandy whiteboard. I'm gonna take you guys, or the ones that's interested, subscribe to the channel if you're not already. And I'm gonna take you through how I teach my students and how we mentor, whether you're an LPN, an RN, looking to get into coding, that's what I'm saying. I train and I've done a lot in the medical coding industry, from teaching to education, training nurses to do CDI, that's clinical documentation improvement. I held that credential for years, and that's utilizing your nursing with with coding. So maybe you want to advance your career, or you don't want to do patient care anymore, right? But you want to utilize the skills. Okay, so that's another video, but let's get back to the inpatient side of things. So patient comes in with chest pain, that's a code. They find out the patient had an MI, that's a code. And so comorbidities, say the patient suffered a stroke during that hospital stay, so that made the hospital stay a lot longer. So they take the patient to the OR, they do the PTCA, which is the procedure for a stent. They use a drug-eluting stent. There's different codes for that. The patient goes through that procedure without any complications, and the patient is discharged on day 3. So that chart is aging. So it's like money sitting in the hospital. just sitting there. I don't know if you guys remember or watched the movie John Q with Denzel Washington when the little boy suffered. He had cardiac issues for his heart. He fell on the baseball field. But the point I'm making is, remember the blonde haired Caucasian lady who was just like on the money, like, what's going on? Where's the money for this patient? We can't do surgery without the insurance. And, Denzel Washington, which was the father at the time, he was just like, you guys are going to do surgery. I don't have insurance. My insurance lapsed and yada, yada. So the point I'm making is, I remember, like, that's how it is. Like, especially on the inpatient side, when a patient is discharged, it's almost like, you know, you have money sitting on the table. And so we need this coded and we need this sent to the insurance company. We need this sent to billing so that the insurance company can be billed. And I remember working at a large Trauma One facility right here in the suburbs. I live in Atlanta. So years ago, I was at one of the bigger hospitals when I was coding, and literally we would have the CFO, Chief Financial Officer, come down and like ask the inpatient coders like what's going on, or the director, what's going on with this patient's chart. And that's before coding really went remote or telecommute. And we would have to go on the patient floor, obtain the medical record from the patient's physician or the nursing, and we would what we call interim code, so that we can send interim coding is up to that day, and they would send that to the billing department and like bill the insurance company up to date 14. So yeah, so that's what I'm saying. Like, it is a career. As long as people are getting sick, overcoming illnesses, accidents, having babies, like, to get paid to be reimbursed for those services, the way it's set up, our system, and it's not just our system, it's international classification of diseases. And right now in the United States, we're on the 10th modification. So it's international. You need a code. And then it's another level, it's how those codes are categorized. That's where the guidelines come in for the coding. Let's see. Here I go again moving. I'm sorry, guys. But like in the books on the inpatient side, we have the guidelines are in the front of the book. And when I say guidelines, and this is like a book, this is an old book. I keep everything, but this is ICD 10 official guidelines for coding and reporting. So guidelines are something like, they're a guideline for coding. So I'm trying to think. I'm not trying to think. It's so many guidelines. I just don't want to overwhelm the process. Okay, so it's a guideline for, just say, what code you're gonna put first, and that's called a principal diagnosis guideline. The principal diagnosis is, per the guidelines, that condition after study that occasioned the patient to the hospital, the inpatient. What brought that patient, what caused that patient to be admitted to the hospital. So those are guidelines. And for example, patient came in with chest pain. After study, and study is like your imaging, your test, it could be like blood work. Okay, say, let me get off of that. Patient came in with back pain, urinary frequency, I want to say something, but that might be too much information. I want to be like burning, urination, things like that. So those are symptoms. Those are like that's the admitting diagnosis. Like, what brought that patient to the ER? The patient had real bad back pain. The patient was what we call dysuria, meaning painful urination. So after study, after they gathered a urinalysis, when they have you go into the restroom and urinate in a cup, they send that to the lab. So all of that study, like why is this patient coming in with these symptoms? After study, oh, the patient has a UTI, urinary tract infection. So admitting diagnosis, what brought the patient into the hospital? Back pain. So we're going to find a code for back pain. After study, why was the patient having back pain? Oh, after they ran the urinalysis and the tests and the urine culture, they found that the patient had a UTI. So principal diagnosis guideline says, okay, Tasha, after study, why was this patient admitted? Oh, that's easy. After study, the patient had a UTI. So the code for UTI would be the first code on that patient's chart, because that's going to determine the reimbursement. And not only just the reimbursement, but you want to have a quality chart. They're using that for statistics. So for instance, say a coder isn't trained very well, or you're a new coder, or you're not using the guidelines, or you at home and your friend call you, look, this is my phone, and you coding the chart. You like, girl, yeah, these kids, the school called me, I had to pick them up. Oh my gosh. And you get an email, you like, oh, I need this. Let me push this chart through because they need it, or whatever. So anyway, that's an example. And I got my tripod with my phone. Don't laugh at me. I'm somebody's mama. So where was I at? Oh, the inaccuracy of coding and how it changes the reimbursement, and not only the reimbursement, the statistics. So instead of the coder putting UTI for the principal diagnosis, the coder, okay, the patient has hypertension, or the patient has, okay, hyperlipidemia. It's a code. So the patient has high cholesterol or something. So the coder captured all of these diagnoses, looked in the book, found the code for UTI, got the code for hypertension, and what else? Oh, the patient does have hyperlipidemia, and the patient has a history of smoking. So boom, I'm done. So how are we going to put the first code? So the coder puts hypertension as principal diagnosis. Now I know, because I know what we call DRGs, and that's another video. Please subscribe. I'm gonna get all into the DRGs and things like that. So the coder puts hypertension. Patient has high blood pressure. Yes, this patient does. It's charted. I mean, it's written by a physician responsible for the care of the patient. The progress notice sign. Yep, hypertension. Right? But principal diagnosis guideline says what occasioned this patient to the hospital for care. So the UTI wasn't first. It's going to mess with the quality and the statistics of this patient's hospital visit. And if I didn't mention the money, and I'm on the money because I've done a lot of contracts with the government as an auditor, going into hospital systems and auditing their coding. So yeah, and that's going to be an underpayment. Actually, if you put hypertension first and the UTI second, and the hyperlipidemia, the hospital is not going to get paid what they deserve, or what the severity of that hospital case patient was. So yeah, that's why coding is so important. That's why we need skilled and trained coders. That's why I'm so passionate about what I do and what I've been able to do. Not on my own strength, only by the grace of God. And I might not be the shiniest health information management professional out there, but I am one of the best. I have to pat myself on the back through the grace of God, right? So when I started, I didn't know anything, but I have traveled. When I started having to travel to Manila, Philippines, in India, to train individuals internationally, not just to do coding there. No, the hospital systems over here, I'm gonna let that sit in for a minute. The hospital systems in the United States where people are saying, I need a job, I can't get a job, I don't have money or money or time to go get this degree that may not provide a career, right? And I'm saying job, but this is a career. I'm over there training, leaving my family, training, beautiful experience on company time, but train and meeting beautiful people. Like that was an experience. I'll have to talk about that again later. But the point of the matter is coding is essential, coding is needed, coding is learnable. Um, get a mentor, get a coach, a coach and a mentor, as I've always heard, will collapse decades into days for you. And part of my passion for my business, this is my baby. I have people helping, mentoring, and coaching, but I'm always like in just to make sure that people are getting what I wish I had gotten. So, yeah, but yeah, that's what coding is. Before I get into, I just, the passion in me is like, people need to know. People need to know that this is a career. People need to understand that it's a rewarding career. Um, it helps you in so many ways. I've been able to speak on the level um, that the physicians can respect, that I'm not a lay person. I've had so many medical professionals ask me, from trauma surgeons. I mean, going through things with my parents when they were going through their health crises, just physicians asking, what do you do? Who are you? My sister, before she transitioned, she was a registered nurse. And I had my sister ask, Tosh, what, you know more than me. I mean, not more than her, but I don't do clinical I've been to the extent that I've had the privilege to travel the world and as a consultant all through the United States. I've counted, it's 7 states that I haven't traveled to as a consultant, whether I was doing consultant coding inpatient, consultant auditing, consultant teaching and education, and of course, being what we call a RAC auditor. And those are auditors for the Medicaid and Medicare program through the federal government, CMS. They have auditors to go in and just make sure the chart is coded correctly. They'll send their auditors in. So, yeah, that's coding in a nutshell. Like I said, if you want to learn more, I'll be breaking down each system. I'll be exploring a lot of the a lot of the career opportunities and the benefits. Now, everything 9 times out of 10 is electronic health record. When I started, it was going in, which is fine. I didn't mind that. But to be in your home office provides work-life balance. And this is not a career where you're connected to the phone. Like I said, phone, and my phone started ringing with a headset. We wear headsets sometimes, or people do. But if you're working at a call center and people say like, I work from home, my daughter, I probably talk to my daughter every other video, but my daughter, she was working for, I think, Home Depot or a call center, probably two, but that's not working from home because she couldn't go to the bathroom without the ding in her ear, or if she did, she'd have to rush back This is like when I talk about work life balance, when I talk about the flexibility, I'm talking about your hours. I'm talking about if you need to go pick up your kids like they call. I'm talking about being able to fix dinner, do laundry, run to the gym, um, adjust your schedule, um, what works for you. When we first, what was I? I've been, well, I travel. I've been traveling, but I've been home. And look, I'm not going to do this. But yes, that's medical coding. I'm passionate and I just want, like, if you're interested in coding, if you're interested and you don't know what to do, like, God has used me through this profession to sound the trumpet or to bring an awareness, um, and be that coach, that mentor, that resource. So click the subscribe button. Thank you for tuning into the video, watching it to the end. I'll be back with more coding nuggets. Click the subscribe button and hit the bell so you can be informed for every time a video drops. And put your comments down below. I'll be reading the comments. Hopefully, I can answer your question. If you're not able to get the answer that you're looking for, you can also go on, click the description, my website. You can book a free consult with me, and yeah, we can discuss it more. Thank you. Have a wonderful day. See you in the next video.